So remember very carefully, because the difference between electrotonic potential and action potential very frequently asked during your Viva examination, and it is also a very common question which is supposed to come in your professional examination. Okay, so so a little recap: the difference between electrotonic potential and action potential. Okay, so it fades out. Electrotonic potential, it fades out exponentially and it travels, it has a saltatory conduction. Saltatory conduction, right? EP is a passive phenomenon and action potential is active phenomenon. It requires sub-threshold stimuli, and it requires threshold or supra-threshold stimuli, right? Okay. Any more differences? The change in membrane potential, or del Vm is less than is equal to 15 millivolt, and in action potential, del Vm or change in membrane potential is more than 15 millivolt, right? For electrotonic potential, the critical number of sodium channels do not open simultaneously, right? Critical number of sodium channel do not open simultaneously. On the other hand, for action potential, you need to open critical number of voltage gated sodium channels to open simultaneously, right? So you have these 6 or 7 differentiating point between electrotonic potential and action potential. Now remember, cells, depending on its nature, has got different shape of action potential, right? So you have different excitable cell. We have given examples of excitable cell. You know what are excitable cells? The skeletal muscle cell, the smooth muscle cell, cardiac muscle cell, and the neurons. These are major excitable cells in your body, right? And the action potential we find in those cell membranes, the shape might be different according to the cell. Say for example, in a skeletal muscle, right? In a skeletal muscle, or simply in a neuron, you will see the shape of action potential is this, right? This is the shape of action potential in a neuron, right? And if you take a myocardium, a cardiac muscle, the shape of action potential will be somewhat like this, right? Now another important question for you is the ionic basis of action potential. What are the major ions that are responsible for giving the particular shape of action potential, right? So if you split one action potential, it has got one upstroke, one downstroke, and some downstroke are even below the baseline, right? We call it hyperpolarization, right? So this upstroke is called depolarization, okay? This upstroke is called depolarization, the downstroke is called repolarization, and sometimes it's overshoot below the resting membrane potential, and it is called the hyperpolarization. Clear? Okay, so depolarization, repolarization, hyperpolarization, and yes, again come back to resting membrane potential, right? And if you look at myocardium, the action potential is different, the shape is different. So what is the major difference between the action potential which is happening at a neuron and an action potential which is happening in a cardiac muscle? Okay, so this one is the action potential happening in a myocardium. So again you see one upstroke which is called the depolarization, and yes, there is a downstroke as well, that is called the repolarization. So there is no hyperpolarization over here, right? But you have a typical resting phase, right? Which is depolarized, which is not the resting membrane potential. So it is well above the resting membrane potential. But there is a stationary phase, right? So membrane potential is fixed, and this phase is called the Plateau phase. This phase is called the Plateau phase, right? Okay, now you need to know the ionic basis of action potential, how action potential is generated and what are the ionic basis. Okay, as we are discussing, we are in cardiovascular system, so we are more concerned with the action potential happening in a cardiac muscle, right? So during your neurology classes, we will discuss the action potential happening in a neuron, right? But right now we are concerned with the cardiovascular system, and we are discussing electrophysiology of the cardiomyocytes, right? So we will describe in details the shape of action potential in a cardiac muscle and also the conduction tissues, right? So now let us give you a brief idea on the conduction tissues, right? Okay, so what are the conduction tissues of heart? First, it starts with SA node, right? First, it starts with SA node. You all know that action potential is generated from, it is an autorhythmic tissue, right? Conduction tissue. So first impulse is generated from SA node. From SA node, we have AV node, which is at the upper border of interventricular septum, right? And from SA node to AV node, there are internodal tracts, right? Internodal tracts. So you have got this SA node, then AV node, right? So here is your right atria, this is left atria, and right atria, left atria. Now this one is your ventricle, left ventricle, right? So SA node, AV node, right? This is internodal tract, correct? From AV node, you have got the bundle of His, and at the mid part of the interventricular septum, this bundle of His, it divides into right and left branch. This right branch supplies the right ventricle, and left branch, it again divides into two. One is the anterior fascicle and another is the posterior fascicle, right? This is posterior fascicle, this is anterior fascicle. This one is your LBB, left bundle branch, or this is your right bundle branch. And if we separate these conduction tissues from the heart, so we see like this is SA node, this is AV node, this is bundle of His, which divides into two, the left bundle branch and the right bundle branch. Right bundle branch supplies the right ventricle, and left bundle branch, it divides into the anterior fascicle and the posterior fascicle. Because you know, I am drawing it two-dimensional, but heart, it is a three-dimensional structure, right? It is a three-dimensional structure. So this branch or left bundle branch, it divides into two. One branch supplies the posterior part of the left ventricle, and another branch supplies the anterior surface of the left ventricle, right? So here is the total conduction tissues. This is SAN, this one is AVN, this is bundle of His, which divides into right bundle branch and left bundle branch, right? And left bundle branch has got posterior fascicle, and this one is anterior fascicle. So this one is the conduction tissues. Now one major question that appears, what is the role of these conduction tissues? Right? And what is the difference between conduction tissues and the remaining myocardium? Right? So what are conduction tissues? Conduction tissues are basically the wirings. Right? Conduction tissues are basically the wirings. Just like the copper wires that supply electricity from one place to another. Right? I am switching it on here, and there one AC is running. Right? So copper wire is there, which is conducting electricity faster, correct? So this is the role of conduction tissues. So in my previous class, we have discussed that in heart, if I am able to depolarize one cardiomyocyte, the remaining cardiomyocyte which are adjacent to the cell which has generated action potential, all the cells are depolarized, and as a whole, the whole heart is depolarized and the ventricle contracts. This is the rule. So if you suppose all the cardiomyocytes like a brick in the wall. So one brick is depolarized, all the bricks are depolarized because action potential travels from one cell to another. Okay, so had it been the situation, if this is the situation, if I depolarize one brick and all the bricks are depolarized, then what is the use of these wires? Getting my point? So the function of wires are to take electricity from one place to another. Okay, but in case of heart, wires are not required, because if you depolarize one cell, the nearby cells are depolarized. Again, nearby cells are depolarized. Okay, so absolutely we don't need any wirings to travel, to conduct or to transport electricity from one place to another, right? Okay, so the conduction tissues, the SA node, the AV node, the internodal tract, bundle of Hayes, the Purkinje fibers, right? The left bundle branch, right bundle branch, anterior fascicle, posterior fascicle. These are nothing but the specialized myocardium, the specialized cardiac tissue, which has got more gap junctions, so that they can conduct electricity faster than the normal myocardium, which has got a fewer number of gap junctions. So the only difference is the number of gap junctions. You know that cardiac muscle cells are coupled together electrically. If one cardiac cell is depolarized, the remaining the adjacent cardiomyocytes are also depolarized. But this will happen faster when the number of gap junctions are more. Gap junction forms a tunnel between two adjacent cells, right? And there is a specific protein called connexin. Okay, one cell contributes 3 connexin protein, another cell contributes connexin proteins, and now a tunnel is made. So how fast the action potential will travel from one cell to another, it depends on the number of gap junctions between the two cells. And these conduction tissues, starting from SA node to the Purkinje fibers, these conduction tissues has got numerous number of gap junctions, so that action potential travels faster. Jodi this conduction tissues now thakto, tahole gota heart ke depolarize kora jeto. Okay, but the pace will be less, right? Okay, so to do it faster, to travel action potential faster than it is supposed to be, we need conduction tissues, we need wiring, right? Okay, one brick to another brick, দেওয়ালে যত brick আছে, one brick to another brick, action potential spread করা possible, but we need a faster way, we need a faster connection. So we made some specialized bricks. Through that particular route, action potential will travel. Our sole aim is action potential is being generated from this place, right? From this place action potential is generated, and it is traveling and depolarizing the whole ventricle, right? So action potential starting from here, and it is depolarizing the total heart, right? So as if an Wi-Fi signal is spreading through this place, and it is covering up to this point, right? So this is why we need these conduction tissues. Okay, say for example, okay, tell me how much time is required to depolarize the heart? If I send a signal from SA node, how much time is required to depolarize the whole heart? It is the time for the systole, right? So ventricular systole, if we take a heart is beating at a pace of 72 per minute, okay, heart is beating at a pace of 72 per minute. So what will be the timing for a single beat, for a single cardiac cycle? 0.8 second. Simply just divide 60 by 72, you get 0.8. So 0.8 second is the total duration for systole and diastole. For ventricle, systole and diastole is 0.3 second plus 0.5 second. Okay, for atria it is 0.1 plus 0.7. Okay, as we are more concerned with the ventricle, we are considering ventricular systole and ventricular diastole. So total 0.3 second. Okay, the total ventricle is getting depolarized, and there is a systole. Clear? Okay. So conduction tissues যদি আগে না থাকতো, conduction tissues যদি না থাকতো, তাহলে কি হতো? The time would have been more than 0.3 second. Clear? So the conduction tissues, this SA node, AV node, internodal tract, Purkinje fibers, all these things are nothing but myocardium with more number of gap junctions. They can transmit action potential at a faster pace, right? They can transmit action potential from one cell to another at a faster pace. Okay. Conduction tissues na thakleও action potential atria থেকে ventricle চলে আসতো, but it would have been slower, right? So the mechanism of calcium entry and the further contraction here in this picture. So depolarization wave or the action potential which is traveling from one cell to another, right? So it will open the L-type calcium channel. It will open the L-type calcium channel on the T-tubules, right? T-tubules are just the invagination in the cell membranes, right? So within these T-tubules, there are multiple this L-type calcium channel, long-lasting calcium channel, right? So calcium will enter through this channel. Calcium will enter through this channel, and it will act on a receptor which is located on the sarcoplasmic reticulum, right? On the sarcoplasmic reticulum, the specific receptor is called ryanodine receptor, right? That specific receptor is called ryanodine receptor. And you remember, extracellular calcium is required for cardiac muscle contraction. Okay, extracellular calcium is required. Skeletal muscle may contract even without extracellular ECF calcium. Okay, we will discuss it when discussing the contraction relaxation mechanism in a skeletal muscle, right? So extracellular calcium is required. Calcium will enter through this L-type calcium channel, and it acts on this ryanodine receptor. Okay, and once this ryanodine receptor is activated from this sarca, calcium exits, right? And now the intracellular calcium is high, right? Once intracellular calcium reaches at a particular level, there is contraction. And finally, after the contraction, we will discuss this mechanism detail when we will compare the contraction mechanism between a cardiac muscle and a skeletal muscle, right? For now, just remember extracellular calcium is required, depolarization wave travels and it activates this L-type calcium channel, calcium enters through it, and this calcium interacts with the ryanodine receptor which is located on the sarcoplasmic reticulum membrane, and within the sarcoplasmic reticulum there are numerous sources of calcium, and this calcium comes out within the intracellular fluid, and once in the intracellular fluid or ICF, calcium level reaches at a certain point, there is contraction, right? And this is the mechanism. And once contraction is over, that calcium goes back into the sarcoplasmic reticulum through a specific pump called sarca pump, right? Okay, now here are the shape of action potential, and at the same time we have depicted ECG wave, right? So you see the shape of action potential is changing starting from SA node to the ventricular muscle, right? The shape of action potential here it is for SA node, here it is for atrial muscle, and come to ventricular muscle, you see the shape of action potential is this, right? So initially, at the beginning in SA node, actually there is no play 2. The shape of action potential is one upstroke, one downstroke. Okay, upstroke, depolarization, repolarization, and slight hyperpolarization as well. This is the shape of action potential in SA node, right? And come back to ventricular muscle, the shape of action potential, there is no hyperpolarization, but there is one play 2 phase. Clear? So you should remember the shape of action potential starting from SA node to the ventricular myocyte. Okay, at least you need to remember 2 different types of action potential. One is happening in the conduction tissues, and the prototype example of conduction tissues will be SA node. So you remember the shape of action potential at SA node and also the shape of action potential in a ventricular muscle, right? These 2 are must, right? Now I am coming to the ionic basis. Okay, before that, the speed of conduction. The speed of conduction in SA node, it is 0.05 meter per second, and come to ventricular muscle, it is 1 meter per second, and the speed is highest in the Purkinje fiber system, which is 4 meter per second. Very frequently it comes as a MCQ in your NEET PG. Nowadays for yours it is next PG examination, right? So MCQ will be formed like that. The speed of action potential is highest in option A, SA node, option B, AV node, option 3, Purkinje system, option D, ventricular muscle. In this way MCQs are formed. Okay, so you remember the speed of action potential or the conduction rate, it is highest in the Purkinje system, right? Okay, so this is one point to remember. It is at the very beginning you need to memorize very, I always tell you physiology is a conceptual subject, okay? But it is not conceptual right now. At the beginning you should be memorizing something, okay? So at the beginning you need to memorize something, and once you memorize, and after a certain time it will become a reflex and it will be a conceptual subject. But to grow that concept, you need some baseline data, and that you need to remember. Okay, now pacemaker, which very frequently in your examination, the pacemaker's tissue is SA node, but there is a hierarchy. Normally in a healthy heart, SA node is your pacemaker tissue, which beats at a rate of 72 to 100 per minute. But once SA node fails, AV node takes its action. Once AV node fails, then other conduction tissues and maybe the ventricular myocytes takes its action, right? Okay. So now what is pacemaker? The term pacemaker activity refers to the spontaneous time-dependent depolarization of the cell membrane that leads to an action potential in an otherwise quiescent cell, right? So important is spontaneous time-dependent depolarization. So SA node has got the property of spontaneous time-dependent depolarization. So we are not applying any external stimulus. In my previous class, I was telling that if you apply some stimulus to a cell, the cell fires, it generates electrotonic potential, and after reaching the threshold stimulus, it shows you the action potential, right? But what is happening in a cell, excitable cell like SA node, there is no requirement of any external stimulus. Automatically it reaches to the threshold and it fires an action potential, right? So it is spontaneous time dependent depolarization of the cell membrane. Okay. Okay, pacemaker potential. Okay, what is pacemaker potential? So first see the picture and then we will define what is pacemaker potential, right? So yes, this one is the shape of action potential, very typical shape of action potential in SA node, and it is called the slow response action potential. In heart, there are two different types of action potential we notice. One is fast response action potential and another is slow response action potential, right? In SA node, what we see, it is the slow response action potential. Okay, I told you, you need to remember two different shapes of action potential happening in heart. One is happening in the SA node and another is in the normal myocardium or ventricular myocyte. Okay, and these two different types of action potential is slow response action potential and fast response action potential. Slow response action potential in SA node and other conduction tissues, and fast response action potential in ventricular myocytes. So this is a typical example of slow response action potential, and here is the ionic basis as well. Here is the ionic basis as well. This one is phase 0. Okay, there is no phase 1 and 3. There is no phase 1 and 2, right? So after phase 0, you get phase 3 and phase 4, right? So these phases are universal. You can't name on your own. You cannot make it 1, make it 2, make it 3. No, nothing like that, right? So there is a convention. This one is 4, this upstroke is 0, this one is 3, and again this one is 4, right? Okay. So for you, the question is, what is the ionic basis of action potential in SA node? What is the ionic basis of action potential in ventricular myocyte? What is the ionic basis? Matlab, during phase 4, what are the ion channels that are operating? What are the ion channels that are operating in phase 0? What are the ion channels that are operating during phase 3, etc., right? Okay, so if this question comes in your examination, write the ionic basis of action potential in SA node. Or the question may come as write the ionic basis of slow response action potential. Same answer. Because the action potential which is happening in the SA node is slow response, right? So question may come as write the ionic basis of action potential in SA node or write the ionic basis of action potential, ionic basis of slow response action potential. So both answers are same. And you believe me, if you do not write anything, you just draw this picture, I'll give you at least 10 on 10, right? Okay, so your answer should be specific, not much. Okay, we don't have much patience to write, to read out all the paragraphs you have written. Absolutely not. So this is not history or literature or something like that, right? So even if it has got 10 marks and the examiner asks you in your theory examination, write down the ionic basis of action potential in SA node or write down the ionic basis of slow response action potential, simply you draw this diagram and believe me, I'll give you 10 on 10, right? Okay, but it should be correct, right? So you see the resting membrane potential, although I'm calling it resting membrane potential, there is no typical resting membrane potential in SA node. Okay, so what I'm explaining is ionic basis of action potential in SA node. Okay, topic is ionic basis of action potential in SA node. So we have a resting membrane potential for each membrane, but here you can see it is 60 minus 60 millivolt. Minus this y-axis is voltage change and this x-axis is time, right? X-axis is time, y-axis is change in membrane potential. And you see the resting membrane potential is minus 60 millivolt. Okay, but you should not tell it resting membrane potential because by definition SA node is an autorhythmic cell, auto-excitable cell, and it has no specific resting membrane potential. SA node का कोई specific resting membrane potential नहीं होता है, right? And this is the reason the cell is excitable. The cell is autorhythmic. The cell is pacemaker. Any pacemaker tissue. Can you name another pacemaker tissue outside the heart? Heart chhada ar ki pacemaker cell ache. May I ask you this question? Pacemaker cell is not only SA node. Any other place other than heart? AV node is also located in the heart. When SA node fails, AV node takes its action. Okay, and it becomes pacemaker, right? But what my question is, other than heart, is there any other location where pacemaker tissue is available? Interstitial cells of Kajal in gastrointestinal tract, right? In your brain, right? The cells which are responsible for generating electrical signals, and we record EEG, electroencephalogram, right? Okay, anyway, come back to SA node. Okay, so SA node has got no specific action potential, no specific, resting membrane potential, and its resting membrane potential fluctuates from minus 60 to minus 30 millivolt, right? It's minus 30 to minus 40 millivolt, right? Minus 60 to minus 40 millivolt, its resting membrane potential fluctuates, right? And this dotted line is the threshold, which is around minus 40 millivolt, right? Which is around minus 40 millivolt, the threshold potential, and once it reaches the threshold, it fires, right? And the upstroke is called phase 0. This repolarization is phase 3, and again this phase 4, and it keeps on continuing. Okay, during your examination, if you were to draw the diagram of pacemaker potential or the action potential which is happening in the SA node, just put a tick. Okay, put a tick. So you put a tick and extend it is in this way, right? Okay, and it makes an action potential happening in SA node, right? Okay, so this one is the tick, this one is the tick, and again draw this. Again tick, again draw this, right? So in this way, you can draw the action potential happening in SA node. Now they come to the ionic basis. Okay, check the difference. check the difference between action potential happening in SA node and the action potential happening in cardiac myocyte. This is the action potential happening in SA node, and see this is the action potential happening in cardiac myocyte. Okay, and below that we have a ECG signal. Okay, when we are capturing this electrical signal, the action potential within the heart from the surface, right, from the surface of skin, from the skin surface, we are getting this signal, which is ECG, right? Inside within the heart, this electrical signal is happening, and from outside, from the skin surface, we are recording this as ECG. Clear? Okay? Okay, now come back. This is SA node. So phase 4, okay? You see in phase 4, two major ion channels are responsible for phase 4 depolarization, right? Okay, phase 4 is the depolarization where membrane potential fluctuates from minus 60 to minus 40 millivolt, right? And this phase 4 is actually called the pacemaker potential. Now come to the definition of pacemaker potential. Every rhythmically discharging cells have a membrane potential that after each impulse declines to firing level. Why it is called declining? Because declining to firing level, right? Each rhythmically discharging cells maintains a membrane potential which automatically after each impulse declines to firing level, right? So within this, what is pacemaker potential? Phase 4 or phase 0 or phase 3 or what? Phase 4 is the pacemaker potential. Again comes as the MCQ. Okay, so they will give you the picture of an action potential happening in the SA node, and which one is pacemaker potential? Phase 4, phase 0, phase 3, both phase 4 and phase 0. They'll give you options like that, and your answer should be phase 4. Okay, so phase 4 potential is called the pacemaker potential. Okay, so you have got phase 4 pacemaker potential, then the depolarization 0, then 3 the repolarization, right? Now come to the ionic basis of action potential. During phase 4, so what currents are operating during phase 4? You check during phase 4, you have this green color current, and this majority is due to this red color current. Okay. So this green one is the calcium channel. Okay. This green one, within bracket it is written as T because it is transient, right? So this calcium channel and this F current. Now some points regarding this F current, which is called funny current. Okay, which is called funny current, right? This IF, and this IF or this funny current is mainly responsible for this diastolic depolarization. Okay. For this diastolic depolarization or for this pacemaker potential, the major ion channel responsible is the funny channel, and the current called is funny current. Why? The name of this specific ion channel is HCN channel. HCN channel. Hyperpolarization gated cyclic nucleotide activated. Hyperpolarization gated cyclic nucleotide activated, right? Hyperpolarization gated cyclic nucleotide activated. So it is called HCN channel or funny channel. The current is called funny current. Why? Because it is a non-specific cation channel. Like this channel, this green color, this channel is specifically for calcium. But this funny current, it can pass sodium, it can pass calcium, it can pass potassium. It is a non-specific cation channel which is responsible for phase 4 diastolic depolarization, right? Okay, funny current, and you know this funny current has got major clinical application, right? we can change the conduction of this funny current and we can change the heart rate as well by giving some drugs which acts on this funny current. Okay, it is not required. Nobody will ask you in your first professional MBBS the drug or the medication that blocks funny current, right? But the name of that drug is ivabradine, right? So it is a drug that blocks this funny current, right? So very often we use this drug in a case of heart failure or in a case of myocardial infarction. Frequently we use this drug to reduce heart rate. If you see this, so this is a single action potential, right? This is a single action potential, and this phase 4, the inclination of this phase 4 determines the heart rate. বুঝাতে পারলাম কি? This phase 4, it determines your heart rate, right? Inclination of this phase 4 determines your heart rate, right? So see this, yes. So this one is the control, this is phase 4. Now if you make it more flat, your heart rate will reduce, right? Getting my point? So this one, all these are action potentials happening in SA node, right? This is normal, this orange color is control, normal. Now if you block this phase 4, okay, it will be flatter, right? It will be flatter. And now you see 2 spikes, right? So there are, within this region, you have 3 spikes, right? 3 action potentials in the SA node. The number of action potential in SA node is your heart rate. Okay. So if you make your phase 4 diastolic depolarization more flat, your heart rate is reduced. You get only 2 spikes. Getting my point? So by giving some drug, you can change the steepness. You can change the steepness of phase 4 diastolic depolarization. If you make it more flat, heart rate will reduce. If you make it steeper, your heart rate will increase, right? So ivabradine, which blocks the funny current or the HCN channel, if you give this drug to a patient, heart rate will fall, right? Clear? Because this drug will block this funny channel and the phase 4 diastolic depolarization will be flatter and it will reduce your heart rate. Clear? Okay. Now come to phase 0. Phase 0 is due to long lasting calcium channel. You should remember it, right? And phase 3 is due to potassium current. Okay, it is due to potassium efflux, and again phase 4, right? So it is very simple to remember the action potential and very simple to draw as well the shape of action potential in SA node, which is also called the slow response action potential. It has got 3 phases, phase 4, phase 0 and phase 3. Phase 4 is called the pacemaker potential or diastolic depolarization. It is due to 2 current. One is transient calcium channel and another is funny current. Another name of funny current is HCN current. HCN full is hyperpolarization gated cyclic nucleotide activated, right? Okay, and one drug, ivabradine, which blocks the funny current, which causes the phase 4 flatter so that heart rate falls, right? And if you give the patient beta agonist, if you give the patient beta 1 agonist drug, right, sympathomimetic drug, what will happen? Phase 4 will become steeper and heart rate will increase. For example, noradrenaline. If you give the patient noradrenaline, what will happen? This phase 4 will be steeper and heart rate will increase. If you give ivabradine to the patient, this phase 4 depolarization will be flatter and heart rate will fall. Okay? Now come to phase 0. Phase 0 is due to long lasting calcium channel, then phase 3, it is due to potassium efflux, due to potassium current, again phase 4, right? Okay? Okay. So, ionic basis of SA nodal action potential or ionic basis of slow response action potential. Very, very, very important. Remember throughout your career. Never forget. Okay. Irrespective of your specialty, you become what? You become a physician, you become a surgeon, you remember pacemaker potential. Very important for you. Okay. So, now the shape of action potential happening in a cardiac myocyte, say for example ventricular muscle. Okay. So, how does an action potential look like in a ventricular myocyte? And it is, you see, it is different from the action potential which were happening in SA node, right? So, the major difference is phase 4 is flat. Major difference. What is the major difference? Yes, phase 4 flat. Okay, phase 4 flat. There is phase 0 as well. Phase 0. There is two separate phases, 1 and 2, जो वहाँ पर नहीं था, right? So here we have phase 1 and phase 2. Okay, phase 2 is the major difference because phase 2 is plateau. Phase 2 is plateau. There is no change in membrane potential. Okay, so y-axis here, y-axis is change in voltage and x-axis is time, right? So according to y-axis, you see phase 2 is flat, no change in membrane potential, right? Okay, now again you need to remember what are the ion channels that are acting in different phases. Okay, phase 4 is flat at minus 96 millivolt, which is considered the resting membrane potential of the cardiac myocyte. Okay, so we have a fixed resting membrane potential in case of cardiac myocytes. In contrast to SA node, where there were no specific resting membrane potential. SA node का कोई fixed resting membrane potential नहीं होता है, and it fluctuates between minus 40 to minus 60 millivolt. Okay, and this is why it is excitable. This is why it has got autorhythmicity. And this is cardiac myocyte. It has got no autorhythmicity. Okay, in a healthy heart. In a healthy heart, the ventricular cardiomyocyte, it has got no autorhythmicity. It is not a pacemaker cell, right? So it has got a fixed resting membrane potential minus 96 millivolt, and during phase 4 we have potassium channels acting, and this specific potassium channel is called, it is inward rectifier potassium channel. You may or may not remember because nobody will ask you this specific type of potassium channel at your level. It is a higher level, it is the MD topic or cardiology topic, right? If you say just potassium channel, it is okay for you, right, at your level. But if you want to remember and if you want to write a better answer, you can remember that this potassium channel is inward rectifier potassium channel. Okay, and this phase 0 is due to voltage gated sodium channel. Okay, rapid entry of sodium within the cell. Phase 0 depolarization is due to sodium entry. So here is the another major difference. In SA node, there was no sodium channel. There was no role of sodium channel in SA node action potential. But in cardiac myocyte, this phase 0 is due to sodium channel, right? You see again, phase 0 is due to long lasting calcium channel, right? Phase 0 is due to long lasting calcium channel over here in SA node. But in ventricular cardiomyocyte, phase 0 is due to sodium, right? Sodium entrance. Now phase 1 is very small, just this small downstroke, it is phase 1, and this phase 1 is due to potassium and chloride out, and it is specifically due to transient outward potassium channel. Again, I tell you, no need to remember the specific type of potassium channel. If you want a better answer, you can remember, right? If you just say that it is this phase 1 is due to potassium and chloride out, we'll give you marks, no problem. But if you can remember, it is a specific potassium channel which is called transient outward potassium channel, the answer is really good, right? Okay, so phase 1 is due to transient outward type of potassium channel. Phase 2, which is the plateau phase, matlab voltage is not changing. Okay, something is coming, some positive ions are coming in, some negative, some ions are coming out. So it is making a perfect balance so that voltage is not changing. So what is happening in phase 2? So calcium in, potassium out. Okay, calcium in, potassium out, and it makes a perfect balance so that voltage is not changing, membrane voltage is not changing, and you are getting a play-2. So this is the isoelectric phase. This is the isoelectric phase. Matlab there is no change in membrane potential during that period. If you compare in ECG, okay, in ECG also there is an isoelectric phase, okay, and that isoelectric phase corresponds to this phase 2, right? Let's see this. Okay, so this is the play-2 phase. This is the play-2 phase where calcium in, potassium out, both are acting. This is the play-2 phase, and you see the ECG, again voltage is not changing, you have a play-2 phase, right? And we call it the ST segment. We call it ST segment, right? In ECG. In ECG, we call it ST segment, and in action potential, we call it, these are two overlapping, okay? We are recording the change in voltage outside by an ECG, and internally what is happening in a cardiac myocyte is this fast response action potential, right? This one is phase 4, this one is phase 0, 1, and this is 2. During phase 2, we have this ST segment, right? So in a timeline, so there is a perfect overlap, okay? This is what we are recording from your skin surface by doing an ECG, and this is what is happening within the myocardium. Okay, come back again. So phase 2 is due to calcium in and potassium out, okay, calcium in, potassium out, and it takes a perfect balance of ion entry and ion exit, so that there is no net change in voltage of the membrane, and you get phase 2 play-2. And then phase 3, which is the downstroke, phase 3, which is the downstroke, or called the repolarization, and this repolarization is due to multiple potassium channels acting simultaneously, This phrase is based for you, but if you can't remember, if you can't afford it, you can write all the names of these potassium channels. So potassium channels are slow delayed rectifier, rapid delayed rectifier, and inward rectifier. Okay, there are different types of potassium channel. The classification of potassium channel is absolutely not required for your level. If you just say this is due to potassium channel, that is okay for you, right? So all the classifications over here also, okay? So inward rectifier potassium channel, transient outward potassium channel, slow delayed rectifier potassium channel, rapid delayed rectifier potassium channel, inward rectifier potassium channel. So there is numerous classification of potassium channel. I am not going into the details of classification of potassium channel. So phase 3 is due to multiple potassium channels, multiple types of potassium channels acting simultaneously, right? And again phase 4, coming back to the phase 4, which is only the inward rectifier potassium channel, and which maintains this inward rectifier potassium channel, it maintains the resting membrane potential at minus 96 millivolt. Clear? So this is an example of fast response action potential, which is happening in a cardiac myocyte, typically in a ventricular muscle cell, right? And this one is the action potential happening in SA node, which is also called a slow response action potential. Clear? This is slow response action potential, and this is fast response action potential. So you need to practice this, you need to draw both the diagram, and you need to remember all the phases, phase 4, phase 0, phase 1, 2 if available. In some cell phase 1, 2 not available, in some cells it is available, right? So phase 4, phase 0, phase 1, phase 2, phase 3, again phase 4, right? You need to remember the ionic basis of action potential in both the cells, okay? Now the basic concept of changing heart rate by giving some drug to the patient, okay? The basic concept of changing heart rate by giving some drug to the patient, you need to remember about the phase 4 action potential in SO node, so that you can modify patient's heart rate depending on your requirement, right? Say for example, in a case of myocardial infarction, where you need to reduce the workload on heart, and the patient's heart rate is high, and you want to reduce patient's heart rate, right? You want to reduce patient heart rate, you need to give some drug that flattens the phase 4 diastolic depolarization और phase 4 pacemaker potential. ठीक है, so patient का heart rate कम करने के लिए आपको ऐसा कोई drug देना होगा जो phase 4 को flat कर देता है, right? And the examples are ivabradine or beta blockers, right? Ivabradine or beta blockers. So what is happening? You check this. So here is the situation where we are giving some drug to the patient. So before application of drug, it was the control, the orange color, and after the application of drug, you see the blue color, right? So here phase 4 is more flat and heart rate is reduced, okay? And this is mostly due to the effect of ivabradine or beta blocker, right? Now see another effect. So here what is happening? So you see this shift from this point to this point. Okay, this point was initially minus 60 millivolt, and this point the maximum diastolic depolarization, the maximum diastolic potential, right? Maximum diastolic potential, it has come down from minus 60 millivolt to minus 80 millivolt. Okay. So if you do this again, you can reduce heart rate, right? So here are some effects of, and here is another effect. Here is another effect where you can increase the threshold from this point to this point, right? Initially it was maybe minus 30 millivolt, now it is minus 25 millivolt or like that, right? Okay. So you are increasing the threshold. So depending on the situation, these drugs are used either in a case of heart failure or myocardial infarction. Depending on the situation where you need to reduce the workload on the heart, you need to reduce, heart rate, right? You need to increase heart rate. You can use those drugs, right? Okay. Now the effect of acetylcholine. What acetylcholine does to the heart? Okay. So acetylcholine, it decreases, just remember the fast action, that will be okay for you. So acetylcholine, it decreases IF current, funny current, okay. So acetylcholine, it decreases funny current in the SA node, reducing the stiffness of phase 4, reducing the stiffness of phase 4. So if you give acetylcholine to the patient, so stiffness of SA node pacemaker potential, it falls and there is reduction in heart rate, right? Catecholamines. Catecholamines means adrenaline, noradrenaline. What those drugs does to heart? It increases the funny current, right? Thereby increasing the stiffness of phase 4 potential. And remember one point, that catecholamines do not appear to change the maximum diastolic potential. Okay, catecholamines maximum diastolic potential kono change kore na, right?